We have Steve Hollenberg, and he's going to talk about COVID ARDS induced RV failure, something we're trying to forget, but still around.
The coveted COVID talk, yes, indeed. I'd like to thank the organizers for having me, and I'm going to try to tell you as much as I can in 7 minutes. I'm going to try to show you some physiology, and I'm going to try to show you some data. So really there are 4 questions. Is there evidence of RV dysfunction in COVID? Is this mediated by the heart or lungs or some sort of combination? Does this have independent prognostic significance? And does it have therapeutic implications? So this you all know, you've heard all this meeting that the right ventricle is sensitive to afterload. I'm going to remind you of some of the pulmonary physiology that you probably know. Hypoxia increases pulmonary vascular resistance via hypoxic vasoconstriction, trying to shunt the blood into the oxygenated areas. And it turns out that hypercarbia increases pulmonary vascular resistance as well. So both hypoxia and hypercarbia increase the afterload on the right ventricle. With respect to this, atelectasis is bad because it causes hypoxia and hypercarbia and increases pulmonary vascular resistance. But overdistension is bad too. This is what you remember from medical school with West zones with the high pulmonary pressures, closing down the pulmonary vessels and increasing pulmonary vascular resistance. So one of the ways to deal with hypoxia and hypercarbia in the lung disease is positive end expiratory pressure. And this slide shows that there's an optimal PEEP that you want to have enough PEEP to recruit and decrease atelectasis, but you also don't want to have so much PEEP that you have overdistension. You kind of want that sweet spot in the middle where lung stress is minimized and pulmonary vascular resistance is minimized. And you'll remember that that optimal PEEP is different the effects of PEEP are different in right ventricular failure, left ventricular failure, and normal. In a normal heart, when you give PEEP, you decrease venous return, but that's responsive to fluid administration, and the cardiac output comes back up. With left ventricular failure, PEEP is good. It decreases afterload. It increases cardiac output. However, in the right ventricle, with acute right ventricular dysfunction, PEEP increases the right ventricular afterload. It can shift the septum over into the left side, and that causes a fluid unresponsive decrease in cardiac output. And you'll remember that in COVID they have terrible lungs, and we're using mechanical ventilation and we're using PEEP. So how do you prevent this? Well, you limit tidal volume in PEEP, you avoid hypercapnia and acidosis, and you avoid hypoxia and associated hypoxic vasoconstriction. Easy to say, right? Well, you can do one of these pretty much all the time. You can do 2 of these most of the time, but you really can't do 3 of these, particularly in really sick patients. So it's a dilemma. It's you're sort of in between place where you can't get out of. So here are the 4 questions again. Is there RV dysfunction? Is this caused by cardiac or pulmonary failure? Does it have an independent effect? Should we treat it? And does that make a difference? So I'm going to try to show you some data. So for those of you who can't read this slide, he says, what makes you happy? Data. No. I mean, what gives you deep and lasting satisfaction? Good data. So I'm going to show you a little bit of data from a study that we did. We were in the epicenter up in North Jersey, so we had a prospective registry of almost 2,000 patients with COVID pneumonia at Hackensack University Medical Center. 368 of them had shock defined as in need of vasopressors, and 327 of those had echocardiography, and this is a convenience sample. It was clinician-driven echocardiography with a standard protocol, and we measured left ventricular ejection fraction, stroke volume multiplied by heart rate, you get cardiac output, right ventricular fractional area change, essentially the right-sided equivalent of ejection fraction, and right ventricular systolic pressure. So we divided them into subsets, and you can see them here color-coded. So in the pink is low ejection fraction, low cardiac output, classic cardiogenic shock, if you will. In the green is normal. In the yellow is low ejection fraction but preserved cardiac output, and the blue group is preserved ejection fraction but low cardiac output. And the mortality is over on the right side. For the whole cohort, mortality is 80%. And you can see there really isn't much difference by left ventricular ejection fraction cardiac index subsets. So here are the data. So in this, we looked at PEEP and cardiac index, and if you look at the patients with preserved ejection fraction, because of patient numbers, if you have a normal cardiac index, there's no relationship. But if you have a low cardiac index, the higher the PEEP is, the lower the cardiac index, suggesting that PEEP has some effect on cardiac output in this population. Here are the results by right ventricular fractional area change, cardiac index subsets, and again, pink is low and low, and green is normal, and yellow is low fractional area change, normal cardiac index, and in the bluish is preserved fractional area change, low cardiac index. And here, maybe there's a little result. It looks like if your right ventricular fractional area change is low, mortality is a little bit higher, doesn't quite meet statistical significance. P is about 0.19. Now, if you look at that by subsets by right ventricular systolic pressure, sort of an equivalent of afterload, you get a similar thing. The groups are relatively evenly distributed. And again, 85 and 87% with low fractional area change, 75%. That doesn't hit statistical significance by analysis of variance either. And if you actually look at the relationship between right ventricular systolic pressure and right ventricular fractional area change, you get a result, and you can interpret this any way you want. The statistical the R is 0.2. That's not an entirely impressive correlation, but it does meet statistical significance. There's some relationship, but it suggests there's a lot of other complicated things going on in this very sick population with COVID pneumonia. So, in conclusion, right ventricular dysfunction is common in patients with severe COVID-19 and shock, and appears to be driven, at least in part, by pulmonary insufficiency and positive pressure ventilation. And although right ventricular dysfunction may be associated with a worse prognosis, there's the potential to think about whether outcome may be more closely correlated to pulmonary recovery than cardiac dysfunction. And we've seen that in the patients with these long clinical courses. And whether treatment of right ventricular dysfunction in COVID will improve outcome is at least currently uncertain. Thank you very much. 42 seconds. Jim Burke, you win the under. I had 42 seconds left. 19 slides in 6 minutes and 18 seconds.
Nice.
Can I have a question?
Yeah, any questions from your
Go for it.
Yeah, great talk. Really enjoyed it. Thanks. Do you have a chance to measure troponin as kind of myocardial injury in those patients? And is the right ventricular failure probably the source of the troponin that we all measure? Did you correlate that to anything?
Yes, and we haven't looked at that yet. Yes, we've measured troponin. And troponin correlates with outcome, as you'd figure. It's a little problematic in this sort of study because this is a registry, and so many times the troponin is measured on admission, and the echocardiogram, the echoes, by the way, I should mention, the echoes were done within 3 days of shock. So you have a troponin from admission, and then you have an echo with shock and RV dysfunction, and so we probably could look at it, but I'm not. And so some of the troponins are measured contemporaneously, and then you have the troponins are measured in somebody who just crashed, and that number is high, but that's not entirely revealing. So most of the troponin data are on admission and look at the fact that troponin is there. If you'd like a little bit of my own bias, I think at least some of that troponin release is a marker for the degree of inflammation as much as it is for the degree of left ventricular dysfunction, but that's speculation.
Steve,
Go ahead. I was going to ask if your database had any hemodynamic. I guess I could be remiss if we didn't ask about the hemodynamics in these sorts of situations. Because I think assessing right ventricular dysfunction in the critically ill person with a transthoracic echocardiogram is, dicey at best. And not to criticize the data, I think it's great to have serial data on lots of patients with COVID pneumonia. But was there any sense of hemodynamic correlates, or was that not part of the database?
So that answer is no, and so you recall this is in COVID. So our incidence, the number of people who really had enthusiasm for going in and putting PA catheters in a room with everything is
or even just a CVP.
vanishing. So not even CVPs. Okay. They didn't measure. There were central lines, but people didn't bother to CVPs. Have to go into the room to measure a CVP. So I mean the echo. I take your point, yeah. But the echo data are what they are. You have a right ventricular systolic pressure based on echocardiography in some patients, and it wasn't feasible at all. And
Gotcha.
I take your point. It's not as precise hemodynamics as one would have wanted, but it is what it is.
We'll go to the left of the room, and then we'll have you in the front. So go ahead.
Ali.
I think.
Okay.
Oh, sorry.
Thank you. Okay. All right. Thank you. Okay. I'm asking. Thank you. Great data. The question now for me, a couple of questions. The patients that got vasopressors or became hypotensive, how many of them, what percentage of them required the pressors because of the overdose of the sedatives? Number one. Number two, how many of your patients progressed to require ECMO? And was the prevalence of RV failure in those patients different? And did you change your cannulation strategy because of that?
Oh, okay. So the first question is quite good, and I don't really have an answer, but the answer is clearly some. Some of the patients had required vasopressors because of the vasodilatory effects of sedative agents. It is what it is. We defined shock as shock, and you were on a vasopressor, but you're correct. Some of that might have been, and as you probably know, patients with, particularly young patients with COVID, need these enormous doses of vasopressors. So in terms of progression, we did some VV ECMO, basically that's a hypoxia. We had maybe one or two that progressed to require VA ECMO, one of whom had clear myocarditis and left ventricular dysfunction and such. But it's a good question. I don't have all that information about that.
So Steve, as somebody that now wears a pulmonary and a cardiac hat, what do you think of right ventricular assist device with an oxygenator? So oxy-RVAD versus VV ECMO. I know you may not have practical knowledge at Hackensack, but I'd love your perspective.
So I have to say, and that's the second part. Most of our patients in VV ECMO did not have prominent evidence of right ventricular failure at first. The challenge with all of this is that in patients who don't do well, eventually their ejection fractions and cardiac output go to zero. So, so eventually you're going to have evidence of cardiac failure with low cardiac output, and the question is that the primary cause of the decompensation, or does that just go along? Everything else is failing. Most of our patients who don't survive, as I suspect yours, succumb to refractory vasodilation with multiple organ failure and liver failure and kidney failure and all that. But I have to, my own bias, and I guess I'm standing here, you get my bias for free, is that most of the important support is pulmonary support. Less important. The right ventricle is going to fail when the lungs are struggling, and if you make the lungs better, you're going to make the right ventricle better.
And Steve, is that true for proning patients too? You talked about ventilatory strategies, but other pulmonary support strategies. Were you able to sort of evaluate that and the risk of RV dysfunction?
We weren't. Almost by definition, we have no echoes on prone
Sure.
patients while they're prone, right? So I guess I don't really know this. The prone patients clearly do better with COVID. You know this. So I'm again a little more biased. I think if you prone somebody and they have a response with oxygenation, that's going to help the right ventricle and probably ameliorate right ventricular dysfunction, because you're improving the pulmonary function. And if your proning improves oxygenation, you need lower PEEP levels and lower ventilatory pressures and this and that. All that makes the right ventricle happier than it otherwise would have been.
I have one, can I ask?
Yes.
Sorry, I think I'm the only non-cardiologist around. It's very fascinating. So let me ask you, if you think a high PEEP is associated with RV dysfunction and increased mortality, do you think it's a global phenomena? The reason I'm asking is a lot of people equate, hey, you have your PEEP elevated, so it somehow increases your PVR because of that. But those are done in very healthy lungs where the alveoli is nicely distendable. It distends, impinges on the capillaries and goes up. But we are talking about ARDS lungs, where the PEEP is just a representation that the alveoli is not distending enough. So what you're seeing on the proximal end doesn't exactly translate into what the alveoli is seeing out there. So in that case, can you just say it's like sepsis? Multiple organs fail at the same time. So that's what we are looking at it, rather than trying to say, hey, it's the ARDS which is driving the RV dysfunction.
So it's a good point, and I actually have an answer for it, although not one that's universally applied. I think that it is possible that if the PEEP does, if you get a high PEEP, say, according to ARDSnet, and that does good things for oxygenation, that's probably good for the right ventricle. And probably what you should do clinically when you give PEEP is to do serial echocardiography and follow the septum and the right ventricular function. And if your septum is still okay and your RV is still okay, you can go up on your PEEP, making an attempt to find ideal PEEP for the pulmonary component. And then when you start getting evidence of RV dysfunction and septal shifts, then it's time to back off of the PEEP. And if you back off of the PEEP and now your oxygenation goes to hell, you need another answer VV ECMO, VA ECMO, something like that. So it's a semi-practical way to get at that. I don't think that some patients really like high PEEP, and it is variable.
Thanks, Steve.